Welcome, everybody. We'd like to thank you for coming to the event, joining us for our focused discussion on saving lives. It's an honest discussion about suicide prevention in the military. Joining us today on the panel are Dr. Caitlin Thompson and Ms. Wendy Laxo, Ms. Jacqueline Garrick, Stephen Wolf from the DAV, Adrian Adezato from the DAV, and Warren Goldstein from the American Legion. And I need to back up a little bit. Dr. Caitlin Thompson is from the VA Mental Health Services, and Ms. Wendy Laxo is from is the Chief of Army Suicide Prevention Program at DoD, or correction, Army, and Ms. Jacqueline Garrick is the DoD from the Suicide Prevention Office. Now that I've muddled through that, what I'd like to do is just pass it off to each one of our panelists and have them just take a moment to tell us about themselves and their program, discussion on saving lives, and help us to get a good idea of what we can do as caregivers and family members to help prevent suicide. So with that, I will mute and ask to start with Caitlin. Adrian Adezato from the DAV and Warren Goldstein.
Hi, everyone. I'm getting...
Dr. Caitlin Thompson is from the VA Mental Health Services, and all right, we're having a technical glitch. Is from the is Army Suicide. So stand by one, please. DoD, or correction, Army, and Ms. Jacqueline. All right, so now that we're through the glitches and we've proven that we aren't fail-proof around here, let's go back and I'd like to start off with the introductions. Dr. Thompson, would you please introduce yourself and talk about your program? Thank you.
Absolutely. Hi, everybody. I'm really happy to be here. My name is Caitlin Thompson. I'm a clinical psychologist by training. I work for the VA. I've been working in the suicide prevention field for the last 9 years, and I oversee the VA's suicide prevention program, which is an integrated network and an integrated, it's one of the largest integrated suicide prevention programs really in the world. I'm really happy to talk about it more, but again, very happy to be here. Thanks for having me.
Thank you. We'll just go straight to Wendy Laxo, please.
Hi, yes, thank you for inviting me. We're excited to participate in this program and this event. So I'm Wendy Laxo. I'm the Chief of the Army Suicide Prevention Program. I've actually been in this position for only 1 month and 1 day, so I'm still learning, but just to let you know, the Army's efforts to reduce the incidence of suicide are aligned with our comprehensive approach of its Ready and Resilience strategy, which synchronizes and integrates total Army resilience programs to strengthen our Army and really sustain a supportive environment that enhances resiliency through integrated training, of which suicide prevention will be part of that holistic integrated training. So it just emphasizes that early intervention and those prevention efforts. And we're working with DoD in order to do that with the services too. So that's it. Thank you very much for the invitation.
Thank you very much. Thank you very much for joining us. And Ms. Garrick, would you please tell us about your program?
Hello, thank you for including us today. I'm excited to be participating in this forum. I've been working with veterans and military community for probably 30 years and started working with the Defense Suicide Prevention Office when we stood it up almost 3 years ago now. So we had a report that documented some issues with the way the DoD was handling suicide, and for the last 3 years we've developed an effort to standardize, centralize, oversee, and communicate best practices in suicide prevention across the department. So that's been my role, that's what we've been doing, and we've made, I think, some progress in reaching some of our goals. So I'm excited to get an opportunity to talk about those today. Thank you.
Thank you. And Stephen Wolf and Adrian Adezato, would you please introduce yourselves and talk about what DAV is doing in this area?
Good afternoon. My name is Stephen Wolf. I'm an Assistant National Service Director with the DAV. We're located in Washington, D.C. at our National Service and Legislative Headquarters. I provide direct oversight of roughly 270 National Service officers nationwide. We also have transition service officers located at military facilities across the country. We have outreach programs, homeless programs, voluntary services, and we represent with our national appeals officers located here in D.C. as well.
So what Stephen was talking about our service program. So these officers, these national service officers, transition service officers, and chapter service officers, they're actually kind of like a hub and spoke model. If a veteran comes to us and need help with regards to benefits from the federal government or state government, these individuals are our main service providers for those veterans in the field. My name is Adrian Adezato. I'm the Assistant National Legislative Director for DAV. I oversee the healthcare portfolio and manage our health policy positions when it comes to Department of Veterans Affairs as well as legislation that goes through Congress.
Thank you very much. And then last but certainly not least, I'd like to introduce Warren Goldstein. He's with the American Legion. He's the Assistant Director for TBI and PTSD program. Warren, would you go ahead and tell us about yourself and your program?
Yes, thank you very much. My name is Terry. My name is Warren Goldstein. I'm the Assistant Director for TBI and PTSD programs for the American Legion. Thank you very much for this opportunity. On behalf of our 2.4 million members, we want to thank you for this opportunity to come talk about how important this topic is, not only to the American Legion but to the country as a whole. My role at the American Legion is really to manage the TBI and PTSD programs within the Veterans Affairs and Rehabilitation Division of the American Legion. The division really manages the claims and benefits as well as the healthcare portfolios for veterans and their families. My role is to really look at the existing science and alternative therapies for treating TBI and PTSD. Again, thank you for this opportunity, and I look forward to this forum.
Great, and thank you all very much for joining us. I know that it's a busy time right now, and we really appreciate you taking the time to help with our members' understanding. So our members submitted a list of questions, and we selected some of the questions that seemed to be the most redundant. In other words, that was the most concern among our members. But before I get into those specific questions, I'd like to start off by asking, and I'll direct this question to Dr. Thompson. What are some of the warning signs? So in other words, let me back a little bit. Say, family members and friends and caregivers tend to be the ones who most often see the first signs, but they don't always notice them or fail to recognize the importance of those early warnings. So would you mind taking a moment to help us understand exactly what some of those early warning signs are, and at what point is it appropriate for someone to take action, intervene, or is it, I'll kind of let you answer from there. Thank you.
Sure. Yeah, such an important question. So, there are quite a few warning signs, but really the big piece of it is, are there significant changes in somebody's behavior or in their mood. So, for instance, are they drinking more than usual? Are they coming across as being much angrier? Are they talking about things like, you know, I feel like such a burden on my family? One of the kind of quintessential warning signs, though, is really hopelessness. So are you hearing your family member saying things like, I just don't feel like life is worth living anymore, and I'm feeling very hopeless. And so it's at that point, it's at any of those points, in fact, where when to take action right away. And what does that mean? So there are different ways that one can take action, but really the biggest one is to talk to them and ask them and express your concern and say, you know, I noticed that you've just really been feeling much more angry than usual. What's going on? And so having that reaching out point is especially important. There are times, though, when you really need to take action very quickly, and those are the times when people are talking about the ways that they're going to kill themselves, the plan that they have, that if you find that they're giving away their pets or things that they really loved, or they're taking steps to maybe put together a will, or things that just don't seem right. At that point, you may need to do things like call the Veterans Crisis Line, the Veterans and the Military Crisis Line, which is at 1-800-273-8255. You press 1. It's 24/7 service. Family members and friends can absolutely call on behalf of the veterans, and that's kind of an immediate response. And then there may be other times when a person has a loaded weapon next to them, and you may need to dial 911 and get help immediately.
Me. I appreciate you sharing the insights with us. I know that, you know, a lot of times it's for especially family members, it gets to a point where it seems kind of helpless and not knowing where to turn. So I'm glad that you were able to share the examples of where they can turn. As we go through the questions, if more thoughts on this, or if anybody would like to chime in and add to that, feel free. We'll just move forward. Otherwise, so I'm going to divvy these questions up based on essentially who the target might be on these questions, and by target I certainly don't mean that somebody who's taking shots at our panel, so to speak. So we'll start with Ms. Lasko. We have an Army question, Army specific question, and Richard wrote, I believe this is take that back. Hold on, it's from somebody. First name is Draco. And they asked if the Army has the final say in evaluating mental health issues such as PTSD. And their question got a little, so I'm editing, their question got a little personal towards the middle there, but essentially they want to know if they have another avenue, if they've been told by the Army that they don't qualify or that they aren't suffering from PTSD, what other areas can they go, or does the Army have the last say? So I'll let you take that from there.
Right, that's a great question, and I think really what they're referring to is our individual disability evaluation system, which is our IDES process. And really what that is it's a multiple step process. We actually have 10 stages that a soldier will go through that is in complete integration and coordination with the VA. So the VA does reevaluate, and they do rate conditions that were identified by the Physical Evaluation Board. And I will say, and that is a multiple stage too, but it's a dual process that examines and re-examines for all conditions. So the Army evaluates, the VA also evaluates, and there is an appeal process. So if the soldier doesn't feel that they were evaluated correctly, then they do have an appeal process that they can go through.
And who would they reach out to for help with that appeal process?
There are specific individuals within this IDES process that they can do that. There are lawyers and advocates along the way that they work very closely with. Each individual is assigned an advocate.
Very well. I'll toss this out to maybe Steve or Adrian. Do you guys step in and do any of this kind of advocacies in the reevaluation process and the appeals process?
So yeah, we do. When I mentioned the transition service officers located at the military facilities, this is exactly what they work with. They work with the Army and the Marines and different services to assist with the claims process through IDES or any other nature pre-discharge. And we do have an appeals process at that time. There's many options out there, though.
Very good. Well, I appreciate that. So I guess we'll kind of focus a few questions on general DoD. So I'll take this to Ms. Garrick. So the first question, Larry asked, what do you think is contributing to the alarming increasing rate of suicide among service members who haven't been deployed? And are there telltale signs that can help intervene early? Now, I realize we've kind of answered that question earlier, but so if we could focus on maybe the first part of that question, what do you think, or is there any data explaining why we have a rise in non-deployed members committing suicide?
So what we see when we look across the DoD is that suicide is certainly complex, and that when we bring in young people into the military, they come to us with all kinds of backgrounds and experiences. And what we have to learn how to do is acclimate them to military life. And military life has changed. The last 10, 12 years has certainly seen a change in operational tempo, but it's also seen a change in the numbers of people who are married among the force, the number of people who live on base versus living off base. More soldiers, sailors, airmen, and Marines don't live on base anymore. So there's been different rules about command and getting involved. You used to need your commander's permission before you can get married. Those things have all changed. So we've had an operational environment that's changed. We have very young people who come in, and we find that most of their issues are financial, legal, and relationship issues, and they're young. They're between the ages of 18 and 25. They're junior enlisted. They've had high school education, and we need to give them some of the skills and tools that enable better problem solving, that build resilience, help them make better decisions, and engage in healthier lifestyles.
Thank you. We had a follow-on question from Richard, who paints. I'll avoid painting the picture he's painted, but it comes down to you've led into his question as far as pre-screening. Is the military looking at changing how they pre-screen to try to determine who may be at risk in advance? And if so, is that impacting their recruiting numbers?
Oh, I think I lost you. Can anybody else hear me?
Yeah, I think we all are.
Oh. Well, I can go ahead and answer the question, though. So, no, we have not thought about how we're going to change our screening process, because we recognize that people come into the military, as I said, from all walks of life and all kinds of lifestyle issues.
Well, isn't that fun?
Diversity.
I'm back.
Yeah, I went ahead and answered. I started to answer the question.
I think you're doing fine. You go ahead.
So we know that we definitely have people who come in, and we have not seen a correlation between suicides and waivers and any of the attrition issues or accession issues that have been surmised as being related to suicide. So what we do know, though, again, is that these are very young people. Their lives are complicated and complex, because we live in a complicated and complex world. And what we need to do is really teach them the problem-solving skills and talk to them about resilience. And the Department of Defense has set a definition of resilience. And we do believe that resilience needs to be built and sustained and maintained before it can be used and reinforced. And I think that's where we've looked at things like the mind, body, spirit, and social domain as being important, and teaching those skills across those domains, so that you're teaching the emotional and cognitive skills, you're teaching not only the physical fitness skills, the spirit, the finding meaning, sense of belongingness. I think Caitlin mentioned that thwarted belongingness, that hopelessness, are primary factors. So we really need to make sure that people understand where they fit in and how we acclimate them to military life. That's a slow process. You don't join the military the first day you put on your uniform with a great understanding about military life and culture. You learn that over time. And so learning those skills are important. and building those social support. And that's where I think things like peer support and some of the gatekeeper training, some of the things Wendy was talking about earlier that the services do all train to, are those key skills and those key indicators that will help people live more quality lifestyles and improve their lives even after their transition. We just need to give them the right skills early.
Well, thank you. And I'm going to ping you with one more question before I move on. Let's see. I believe it was. Bear with me just a moment. We've had some technical problems here. So we had a.
And I think we're having more technical problems.
All right, I apologize. So let me just say this right up front. I've given you all a copy of the questions. If I continue to drop off, feel free to self-moderate at any point you feel necessary. So I was just going to ask real quick about the offline or off-base opportunities that people may have. So I know that we had a lot of discussion among our members of Military.com and outside of our membership about the impact the stigma has on self-declaring that you think you may have a problem, so you're afraid to go to your local command. Is there an off-base opportunity outside of the structure to seek help?
So let me give you a couple of talking points on this one, because I think it's really important to recognize that even within the military, we have done quite a bit of educating our commanders about the importance of seeking help, encouraging their troops to seek help, and the need to reduce the apprehensions people have. We know that if you don't seek help early, problems only get worse, and so the longer you wait to get help, if you let a problem, let's say with substance abuse, go on, and you ignore the drunk and disorderly, you end up with somebody who years later then makes a suicide attempt by crashing their car into a tree, and they have a TBI. That's a worse outcome than going to your command, going to somebody else in your unit, going to your chaplain, going to your community resources like a military family life consultant, or calling one of our the crisis line. You can call the Military Veterans Crisis Line. You can call us at Vets for Warriors, where we have peers standing by. And each of the services have other opportunities. If you want to go out into the community, we have set that up through the National Resource Directory, where you can go online, and at this point we have vetted about 15,000 organizations from the federal, state, local, nonprofit. It's all right there. You can put in your zip code, and you'll get and you can Google, like if you're looking for housing assistance, child care assistance, mental health assistance. You put in your zip code, and you can find in your area what's most available to you. There's also joining forces as an opportunity to get involved and help the military veterans community nearest you. And then certainly the veteran service organizations, you've got two of them on the line right now at the DAV and the American Legion that are both great opportunities and know their communities well.
I'd like to add on that, if I
do.
could. This is Wendy from the Army, and I just wanted to add on that the Army has made significant impact in reducing stigma through some innovative programs, one being the embedded behavioral health program that we have that actually takes behavioral health providers and puts them within the footprint of the unit. So they're part of that unit, they see them every day, their offices are right there with the unit offices. So it really has resulted in an increased number of behavioral health appointments. Thanks.
That's really good news. Thank you for sharing that, because again, there's a lot of concern around those kind of stigmas and how they impact someone's ability to not just do their job, but how they're treated by their coworkers and their NCOs and their supervisors. I want to move along now to some questions that will be pointed towards the Veteran Affairs. So this will be back to you, Dr. Thompson. So this has a long preface, because this was actually submitted by one of our reporters at Military.com, Bryant Jordan, and he pointed out that the suicide rates among younger veterans seems to be lower, significantly lower than the older veterans, and he also pointed out that the rate is cut in half again by the amount of activity these veterans have when dealing with the VA for healthcare issues. So he would like to know if you have any opinion on why this is the way it is.
Or yeah, and I think that maybe we need to just quickly do an education on a rate versus like the numbers. So what we know is of our veterans who die by suicide each year, over 70% of them are over the ages of 50. Our rates of suicide, though, of our youngest veterans, and this is the same population that Jackie was talking about, those 18 to 26, 27-year-old young men, those rates are actually increasing. And the rates of the older veterans are, in fact, staying the same and even going down a bit. So, so there are a lot of different reasons why this may be. We know that in the general population, middle-aged to older adults, particularly white men, they tend to have the highest suicide rates. So many reasons for that may be that they're dealing with significant transitions in their lives. Perhaps they are losing a spouse, or they're having more medical problems. They might have retired from their job and are struggling with a sense of purpose. And then with our youngest veterans, those rates may be are increasing, we think, because they're not getting into care right away after they separate from the service. And so what we do know, though, is that treatment works, because another piece that we have found is that those veterans who receive care at the VA have lower rates of suicide than veterans who don't receive care at the VA. And I think that that speaks to, first of all, the fact that the VA's suicide prevention system and structure seems to be working in some ways, and we're trying to figure out exactly which ways. But I think it also speaks to the fact that these folks are getting into treatment, and we know that treatment works. We know that when you get into treatment, you will feel better. So so much of what we're doing is we're both targeting the populations for whom we're most concerned, which is our older veterans, particularly Vietnam veterans, as well as those very, very young veterans. We're also very, very concerned about our women veterans, and their suicide rates also seem to be increasing. They tend to use firearms more than non-veterans, and firearms are the most lethal way to die by suicide. If you use a gun as a way to die by suicide, there's a 90% chance that you will die. Whereas if you take medications, it's more of a 2 to 3% chance. So we're focusing on all of these different things, but lots of reasons to look into and try to better understand.
I appreciate that. I'm glad you clarified the difference between the trend and the numbers themselves. And it is alarming that the trend is increasing. So moving on to the next question. We've had quite a few questions from both sides about the outsourcing portion. So we had someone, and obviously from a consulting firm, who wanted to know why it seems that it's so tough seems as though that the Army and the VA, and they specified the Department of Army, so I would say it's probably more of a DoD question, just because my experience is, are reluctant to involve civilian professional counselors as treatment options, and if so, and what if any guidelines exist for outsourcing some of the clients waiting for services to the very same group of counselors who are ready, willing, and able to help. Now, I'll take the editorial I unfortunately left in, but the point is that he wants to know about expanding the opportunity for outsourcing to civilian providers.
So did you want me to take that, or did you want Wendy to take it? I think you're on mute.
I said I was going to let you guys fight for it. So why don't we go with you since you're on, and Wendy's, sorry, Jacqueline's muted.
Sure. So yeah, especially right now, we know that we have a lot of problems with access, and with the new secretary who's come in, Secretary McDonald, we continue to hire more and more providers to ensure that veterans get into care. I do have to say, though, that we are very, and it may not look that way, but we're trying to make sure that it looks better. But we have, for instance, every year we have mental health summits at our VA where we want community providers to come together with VA so that we can have these level of collaborations. As far as formal outsourcing, that's just not my purview. I don't know how that works. But VA has also, specific to suicide prevention, we've put together a community provider toolkit so that any community members who don't work for VA but still serve veterans, because we know that many veterans get their care in the community, we want to make sure that those community providers are well versed in the issues that come up with veterans that may not come up as much with non-veterans. We want them to better understand military culture, as well as just the specific things that we at VA are doing, educational opportunities, safety planning, so that they can perhaps, we just want to make sure that they feel comfortable to work with the veterans that don't necessarily want to come to VA.
And I'll open that up to Jackie. Did you want to weigh in?
Sure. So I just also, from the perspective of the active duty Guard, Reserve, and our retiree population, the availability of the medical treatment facilities and the TRICARE network is pretty extensive. And we have just established this year a nurse advice line through the Department of Defense to make it easier to schedule an appointment in the continental United States. So anybody can call, get an appointment, talk to somebody at the nurse advice line, and receive an appointment in a timely manner. In the communities, we have agreements with the vet centers. There are 300 VA vet centers that will see the Guard and Reserve as well. And I know there are community-based outpatient clinics. So there is availability out there. If you're having any concerns, though, and any issue with accessing a provider or finding the right level of care, I urge you to continue to reach out, because it is so important that regardless of what you read in the newspaper about the VA or the DoD or any type of care, that you still get it. If you need it, you need to get it. If you're on a medication and it's not working, or you don't like the provider you have, you should still continue to seek care and get help. And if none of that is working, then call one of the 800 numbers. Call the crisis line, call us at Vets for Warriors, and we'll try to work something out for you.
Great, thank you very much. I appreciate you taking the time to help us with that, because again, I think finding care, and I want to make sure that we hammer home something that Dr. Thompson said earlier, and that is that treatment does help. You see results from the treatment, and I think that so many times when you get in that place in your life, you don't feel like anything is going to help, and so you don't really necessarily want to turn to help yourself. So I appreciate that. That's a very important point. Another one of our contributors asked, her name is Tammy, she asked about the high turnover rate. She pointed to her own experience with her husband, and by turnover rate I mean turnover rate of physicians, and the number of times they've had to change doctors in the last 7 years has impacted his healing. And she talked about changes in medication. They finally get one that works, and then they change doctors. So I'll point this back to you, Dr. Thompson. I apologize, but does the VA see a solution to help make that more stable in the future?
Absolutely, and I'm so sorry to hear about that experience. I can imagine how frustrating it may be and how just disjointed it is. You really want to have a healthcare provider who's with you for the long haul. You establish a relationship with them, and you want to continue that relationship. So, and I have to say that it varies. There are other veterans who see their physicians for 30, 40, 50 years. I mean, I've been working in VA for 10 years now, and I'm here to stay. So The thing that that Secretary McDonald is doing right now, though, is he's very much focusing on both recruiting quality providers as well as retaining them. And so they're talking about loan repayment and other sorts of initiatives. So VA is definitely looking at this and trying to understand, because we don't want what happened with her husband to happen to others as best as we can help it.
Thank you. And again, that's the retention issue is big right now, especially with the situations that are been in the news. So we're looking forward to that that being solved. The next question, I'm not sure which would be better to answer, whether it would be you, Dr. Thompson, or Ms. Garrick. But I'll throw it out there, and you guys can again tell me who you want to answer it. So David asked or suggested the possibility of mandatory evaluations, and I'm not sure if he's actually referring to evaluations right at the point of transition or later, though he does clarify somewhat that he thinks that reevaluating older veterans would be important also. Is there any work in that direction, or do you think that's a possibility?
So what I think he's talking about is the pre- and post-deployment health assessment that the Department of Defense does do. All of the service members do go through a screening process before they deploy and when they come back. And we do follow up with anybody who doesn't identify any kind of a need or any kind of an issue. So I think that's how we cover those who deploy. And there is some other opportunities when we do transition assistance programs or yellow ribbon reintegration events for people to come in, go through this very short screening process and have that opportunity to identify issues, to learn about resources that are available, and then make some informed decisions about the level of care they might need next.
Specific to the Army, if you don't mind me just jumping in here real quick.
Please do.
Specific to the Army, we've got 5 different touch points. And so we have one pre-deployment, like Ms. Garrick was talking about, of course. In theater as well, there's a touch point with behavioral health professionals in theater while they're deployed, as well as we have 2 post-deployment assessments, one within 1 to 30 days after redeployment. The other takes place within 90 to 180 days after they redeploy, and then we have that annual assessment. So we've got 5 different touch points for every soldier.
And again, those are mandatory, correct?
Yes, sir, they are.
All right, well, I think that answers his question. Yes, they already have the program. So now I'm going to kind of shift and ask some questions of our veteran service organizations. And so the first one is about resources. I'll let Warren answer this one first. So it says, Kim Williams writes that she would love a list of resources to help her family members and friends recognize possible symptoms and so on. So maybe there's opportunity for everybody to kind of chime in on what they think may be a good resource, but I'll let you start, Warren.
Thank you very much for the question. As you know, part of the American Legion, we have a health care center link to our website, and you can go on that website and pretty much go under the tab Suicide Prevention, and there's a list of all the resources that are available, not only to the service member, but to a veteran and as well as their family members. Anything ranging from the veteran crisis line information to make the connection information to give an hour, to online chatting, signs and symptoms of suicide to include depression, information screening, as well as some quick links as well to really identify the risk factors, warning signs, and also the resources that are available not only to the vets but to family members as well. And also, I think what we're missing here is that each branch has some information on that as well. So it's really important to go to any of the service organization websites, including my colleague here from DAV website, as well as any other veteran service organization or military service organization. You can pretty much find all the resources that you need made available. And you can always go to our website at www.legion.org to find out more information regarding the resources that are available. But I just wanted to also highlight one other thing that that Ms. Garrick said. I think if the individual is seeking care and they're not happy with their services at either the VA or any military base, that there's always a vet center to go to. The vet centers have the staff there available that understand veterans, understand service members. They have the same experiences that they've gone through. They could find peer-to-peer support there because veterans and service members like to go to places where they find comfort. And finding comfort amongst veterans and fellow service members that they serve with is very, very important in the treatment and healing process.
So if I could jump in here, this is Adrian from DAV. So aside from our website, aside from the other veteran service organizations' website, there are two sites I want to point out to participants hang out, and they're both VA sites. One is for the National Center for Post-Traumatic Stress Disorder, and the website is ncptsd.va.gov, and the other website is mentalhealth.va.gov. Both of those websites, and the reason why I recommend folks to go there is because at least for two websites, they're very much dependent on research and evidence and literature. So a lot of the information and the resources that are in those websites are based on research, which is what we want to have out there. I also want to mention that in those two websites, there are two specific pages for family. I'll talk about suicide prevention. I'll talk about coaching into care. Say you're a friend or a parent or a brother or a spouse who's noticing your service member, your veteran, having some issues. You have this gut instinct that tells you they need help. They need to seek help. The coaching to care actually gives you, it's actually a number. You can call them. But what they will do is they will help you with frame of mind. When you speak to the service member, it will help you choose certain words and phrases, either to use or avoid, to encourage the service member or veteran to seek care. I mean, these are very good websites, and I really do hope your participants on the Hangout go to those. Thanks.
That's great insight. We appreciate you sharing that, Stephen. And in a moment, we'll come back to some more of that. But one of the things that Warren mentioned was the peer-to-peer level stuff, and I wanted to kind of maybe just go through the list of everybody here, and if you know of or can talk more about some of the opportunities for peer group therapy that are either while on active duties provided by the DoD or the Department of Army, or through the VA, or even through the Legion posts or a DAV group. So I'll just start because Dr. Thompson is on my immediate left on my screen. I'll start with you.
Thank you, Terry. Yes, so we at VA are just so aware of and of how important peer support services and peer support is. And so we have hired peer support specialists at every VA around the country, and they all have had some experience with mental health problems, and they then take their veterans that they work with along the journey with them of getting through VA care. We continue to enhance the peer support services by having group sessions and incorporating the peer support specialists into suicide prevention and providing suicide prevention training. So we absolutely are very supportive and very find that the peer support piece is so important.
Jackie?
Yeah, so...
do you have examples of how that's applied at the on-base level for active duty?
So what we've been doing is we have the Vets for Warriors program, which are veterans who are on a call line, and you could chat in or email into them as well. They're available 24/7. It's a confidential service, And as I said, they are peers who are trained in providing peer support. I emphasize that because I think we mix up peers and gatekeepers and mentors, and we use some of these terms interchangeably. When I talk about peer support in a paraprofessional way, these are, and just like Dr. Thompson was mentioning with the VA having hired peers, we train those peers to provide a level of support and services. We call it resilience case management, and that's where they do walk through understanding, scoping the problem, working with you to look at solutions, things you think might work for you, and then finding resources, making referrals, and following up. If somebody has anxiety at 2, 3 in the morning, they just need somebody to talk to about what's gone on in their day, that's what the peer can do. The peers take calls from all over the world. We've worked with people aboard ships and as well as in deployed environments. So they call in, they chat in, and we're able to provide a very specific applied skill set that has been very important for the services. We're about to expand that from being a call center to actually put peers in the field. We're having a pilot that's about to kick off at 30 SOCOM locations, Special Operations Command, and we're going to embed peers at the unit level through the commands, and then they're going to train peers who can forward deploy with the unit as SOCOM and the Special Operation Forces operate. Operations continue. This way they can take their embedded peer with them, who's been very trained in a model. A little different from gatekeeper training and that level of peer support, but we think that, and at the department, and our secretary and the VA secretary have both signed a memorandum of agreement to promote the use of peer support and these opportunities. I think the one thing, and I know we've worked with the American Legion on this, so maybe Warren can help me out, where we've talked about looking at how to credential peer support so that at some of these trainings, as we provide master resilience training and ASCARE escort training and assist training and combat operational stress control training, that as we do all of these trainings, that somebody can take those trainings from being on active duty, take them into their civilian life, and either use those certifications towards a degree, like an associate's degree in peer counseling, and then be able to find a job, like the jobs at the VA or at the call center. There are lots of opportunities for peer support out there. I think we just need to do a better job of making that understood as a profession and professionalizing it.
Well, I noticed that we did have some comments from our readers about the fact that it seems to be more powerful when their counselor has those shared experiences and backgrounds. So it's obvious that both the VA and the DoD are taking obviously a lot of steps in those directions. I'll throw this out. Anybody else want to add anything to that about programs they're aware of or something that your group may be providing, and then we'll move on?
So yeah, this is Steve with the DAV. It is true as veterans ourselves to communicate, trust other veterans. DAV offers, we have thousands of chapters across the nation, where although these aren't certified state facilities, they're chapters where veterans go and mingle, have camaraderie, trust, no fear with other veterans alike. And I think that's important for some peer-to-peer structure in a veteran's life. We also have departments that are out there as well. So I just wanted to throw that out there as well.
Great, thank you very much, Steve. I appreciate it. And I'm going to kind of shift gears again and throw out an open question, and we'll go through each of you. You can take as long as you'd like to answer. I think we have about 5 minutes to go. So my question to you is, if you could share one program, one nugget, one thing that you think would really make an impact for our viewers today, what would that one thing be? And this time I'll start with Wendy.
I think a lot of people have stated already to just seek help. If you know somebody that is anxious, if you know somebody that has had risk factors of previous suicide attempts or death in the family or issues with social skills, it's just, help them seek help. And I know Jackie's probably going to talk about, her campaign that she has, and I won't let it out of the bag, Jackie, for you, but she has a great campaign that's just started. And I will say, it's all about seeking help, and it just takes one person to be able to help another. Thank you for this opportunity.
So we'll go ahead and let you chime in, Jackie, since you have a program to tell us about, a campaign.
Well, I think our campaign is joint with VA. It's been on the power of one. So one conversation, one text, one chat, one act can make a difference. And that's where we want you to call the Military Veterans Crisis Line, 1-800-273-8255, press 1. I hope I got that right, Caitlin?
All right, and Caitlin, we'll give it to you next.
Sure. It's just going to be repeating what Wendy and Jackie said. So our Power of One campaign, we're very proud of it because you can really individualize it to your own experience, whether it's the power of one other person, a family member, or just a stranger reaching out and speaking with somebody, or the power of one thing that you can do to really make a change in someone's life. Just small acts can just make that difference. And I also just wanted to say that we have dedicated our lives to do this work. And to those veterans and service members who are out there, we're here for you, and we really want to do the best that we can for you because you are so deserving, and we don't want you to be in crisis or to have thoughts of suicide. And so we're doing everything that we can. We have much more work to be done, but we're here.
Well, thank you very much. Warren, we'll let you go, and then I have a thing or two I need to say in closing with the DAV on this. So thank you.
Yeah, sure. I want to thank all the experts on this panel for participating and inviting us, the veteran service organizations, to participate in this very important forum. Being Suicide Prevention Month, again, we need to take care of our men and women who wore the uniform and fought for this country. But what's important is we always measure how fast a veteran accesses the care. Even though access is important, but we want to also make sure that those treatments and therapies are actually working. So if those therapies and treatments aren't working for you, being the service member or veteran, please seek other treatments such as complementary alternative medicine. And if you're not happy with your provider, don't quit treatment or therapy. Ask for another provider. The VA and DoD military installations have experts in the field of TBI and PTSD and mental health. Please seek the care that you earned and you deserved. Again, thank you very much for inviting the American Legion on this important forum.
Thank you, Warren. And now, before I pass this question to our friends at DAV, I need to point out that because of the earlier glitches, I didn't really hammer home how thankful we are for the DAV's asking us to put on this event. So it was due to your organization reaching out to us and asking us to put this together that this whole thing has happened. So I want to thank you, gentlemen, for your time and really getting behind this, and then give you that chance to let us close out with that one thing that would make the difference in your mind.
Well, thank you. And as Warren mentioned, I want to thank everybody else on the panel, Military.com, for letting this hangout, and all the participants. If there's one thing that I want to impart to everybody on the panel, as well as those participating, is that there is help out there. Legion has help available, VA, DoD, military services. We have help. We have a 877 I'm a Vet. That's a toll-free number. For anybody, it can be a veteran, an active duty service member, the family, a friend. If you're concerned about a veteran or service member, you can call that, and we will get you the help that you need. Steve?
Yeah, I just want to thank the panel and especially the participants out there. And the one thing I want to make sure is understood Please don't wait. If you have a pending appeal or a pending claim, don't wait for a yes or a no. If you need help, take care of your health. Separate your claims and appeals from your health care. That's the most important thing you can do for yourself. And we'll help you with your claims and appeals, but take care of yourself and your health. Thank you.
Great. Well, again, I want to thank all of you for participating. You've spent some time and had to suffer through some early technical glitches to get to where we are, but I think that what you what you shared today is going to be huge. And the nugget I take away from all of this is the fact that treatment helps. It does make a difference, and it just takes that one person in the family or that person themselves to realize they need help and take action. So I'm very thankful for your time, and I appreciate each and every one of you's input. It's been a good event, and I thank you. So on that, we'll say thanks again for joining us, and have a good day.